at first. لبدايتها من دكتورة سانا دلاوجرا hematopathologist, head of pathology department, and I will help you to understand sickle cell disease as possible. So these are the key topics of my lecture. Let's start with the basic structure of hemoglobin.
أجل وابني نواني نأي واستفادة أكلنا من استفادة لما أي واستفادة ولا كيغاني.
I'm not okay. Please listen if anybody is not understanding Kurdish language. So before starting with sickle cell disease is an inherited hemolytic anemia. So when we say anemia, it means that the level of the RBC count or hemoglobin or the hematocrit is below the normal for age and sex. From the start, before entering into the topic of sickle cell disease, it's a type of inherited anemia. Okay, so it's an anemia and it is inherited, and we have a long list of causes of anemia. Simply, it is acquired and inherited. Of the inherited, today we will talk about sickle cell disease. Sickle cell disease is not common in Suleimani, but it's common in Hope, for example, and it's common in the center and the south part of the southern part of Iraq. But it is in the curriculum of Leicester, that's why you have to know about it. Otherwise, you will not face any case of sickle cell disease in Suleimani. But we have cases, we have a good number of cases of sickle cell disease in Dubai, for example. So you don't know when you will work, inshallah, after graduation, or if you decided to work outside Iraq. So you have to have information about sickle cell disease. So before starting with sickle cell disease, let's review your information about the structure of hemoglobin. I will not point, so look at the screen that you like. So obviously, the hemoglobin is a 4-chain structure, or a tetrameric structure, yani 4 types of chains, two similar to each other, yani 2 alpha, 2 beta, yani 2 alpha, 2 gamma. Yeah, 2 gamma and 2 delta. I will show you just in a few seconds. What I want you to know that each chain of the hemoglobin, whatever the name is, there is a heme pocket, KEBD, the black dot in each chain. It is the same. Sorry, again, so focus on the duren. So the heme pocket is in the center of each chain. Inside the heme pocket, there is an iron. And this is the site of binding of oxygen to each chain of the hemoglobin. Yeah, 4 chains, 4 iron molecules with 4 oxygen atoms. And with the binding of each oxygen, the affinity to further bind oxygen is increased, but each chain literally is carrying 1 oxygen molecule, and this is the major function of hemoglobin, as you know. Now, from the name hemoglobin, heme and globin. So heme is the non-protein part of the hemoglobin, and the globin is a chain of polypeptide, which is a chain of amino acids. So this is the protein part of the hemoglobin, to make it easy, okay? Heme, globin. Heme is the non-protein part of the hemoglobin, which is this one, by the way. Okay, heme, and this is the globin. The heme is iron and protoporphyrin, and the globin is a chain of amino acids, or you can say a polypeptide chain. This is just physiology to show you how the مشكلة كيف نعمل سيدي كامل كبشارة كاي أو دانا بابرو I will repeat in each screen bubble. Now, this is the hemoglobin. It comes from binding the protein part, which is polypeptide, and the non-protein part, which is iron and protoporphyrin. Heme is synthesized in the mitochondria. Iron is coming from the circulation through the transferrin, binding to transferrin receptor, coming into the mitochondria, and here we have the iron in the form of ferrous entering into the mitochondria. Then ferrous and protoporphyrin will form the heme level polypeptide or globulin, hemoglobin. This is developing RBC. It means there is a nucleus. Otherwise, mature RBC hemoglobin already is formed or present inside it. Now, here is the same. So this is hemoglobin, and this is the heme part, which comes from which is synthesized in the mitochondria, and this is the globin part. So heme and the globin. Okay, iron is coming from the circulation through transferrin. Transferrin is a binding protein for iron, and it binds selectively to the transferrin receptors. Okay, these are transferrin receptors. Without entering into too much details, just wanted to give you an information about hemoglobin, heme and globin. Now, the next slide is the normal types of hemoglobin in an adult. Recording, I have the lecture recorded, so if you like, I will send it to the representative and you can listen. So Atwani, استعتبري ودواي أشتك فريانة كونتيت. Okay, you didn't catch up information, and you need more information, explanation. I have the lecture of last year. Atwani out and board there. So listen. كامل دوجا تبالش احنا ولا غيره سو اوكي بس هذا زي موضوع هذا بس لا مكان صوت الهواش تاخير شوي او عادي just explanation how the hemoglobin is formed from heme and globin. Is encircled by red. This is the information you need at your level. Otherwise, I would like for pathologists and public postgraduates. Okay. So now you have hemoglobin. You know the structure of hemoglobin. You know the function of hemoglobin. The site of binding of oxygen. Now the three types of hemoglobin in an adult. لوانين بعضك تعمل electrophoresis anemia and bubbling test to quantify the hemoglobin types. Or I will say A, F, and A2. So the main type of hemoglobin in our body is hemoglobin A, abbreviation adult, which is the predominant type, up to 96, 98. Okay, this is the, again, if we do electrophoresis to any one of you, or if we, let's say, not the name of the test, if we quantify the types of hemoglobin in your body, it would be hemoglobin A, the major part, whatever the percentage up to 96, 98. Then we have a minor adult hemoglobin, A2. So it says animal A from adult. And it shouldn't be more than 3.5, from 1.8 to 3.5. And the percentage which is important, this is because you use it to diagnose thalassemia, which is another topic, inshallah, at S6, we will have a lecture about it. The percentage is important for diagnosis-wise. Now, hemoglobin F, which is left here, this is the fetal hemoglobin. Yeah, F means fetal hemoglobin, and it's normal to be 0. Up to 2% is the upper accepted level of hemoglobin F. So hemoglobin A is the adult, then A2 minor adult hemoglobin, then also we have fetal hemoglobin. Percentage is important for diagnosis. That's why we have to know the percentage. Then, there is a term that we need to know before entering into sickle cell disease slides. There's something which is called hemoglobinopathies. Hemoglobinopathies. So what is meant by hemoglobinopathies? It's a disorder of hemoglobin. Excellent. I will talk about this further. Just let's start with the diagnostic term, which is hemoglobinopathies. From the term hemoglobinopathies, it's a disorder in hemoglobin. Whatever the type of the disorder, qualitative or quantitative. So, like hemoglobinopathies, you have to understand that there is a disorder in the hemoglobin. If it is quantitative, which is here, which is thalassemia, as the lecture of, inshallah, 2 years later, it means the level of the hemoglobin, level of the chains of the hemoglobin are not synthesized. The level is less than normal, so this is called thalassemia. But if the level of the synthesis of the chains, that these are the chains, the synthesis is normal, but the structure is abnormal, like there's an amino acid replacement by another amino acid, you call this a qualitative disorder, and this is called structural variant. One example is sickle cell disease. Okay, so here you see that there's an amino acid combining together to form chains, whether alpha or beta. Now, if one of these amino acids is changed by a mutation, the structure of the hemoglobin will be changed. I mean, the structure of the chain is changed, and eventually the structure of the hemoglobin is changed. So the function will be changed, not in every mutation. Some mutations wouldn't change the structure and the function of the hemoglobin. Others will, like for example, we have, I don't know if you have any information about hemoglobin C, hemoglobin D, hemoglobin E, hemoglobin O. There's lipo, there's different names according to the site of, let's say, the country that found the mutation. Today is hemoglobin S. So if there's a mutation changing an amino acid by another one, affecting the function of the hemoglobin, this is called a structural variant hemoglobin, and this is a qualitative defect. Now, the names of the chains, actually, stage, I don't know if you want to memorize it, it's for your sake, but what is important is to know that the hemoglobin is alpha 2, beta 2, and 2 alpha chains and 2 beta chains. The chains are different. When the beta is gamma, this is fetal hemoglobin, and when the beta is delta, this is hemoglobin A2. So, what is qualitative? It means the structure of the hemoglobin is changed, then the function might be changed, not always. Quantitative, it means lack of production of one of the chains, either alpha or beta, sometimes even maybe both of them, but this is rare. Okay, we are still in the introduction. We are just defining hemoglobinopathies. And we said examples of qualitative is hemoglobin S, the topic of your lecture. It could be hemoglobin D, E, or Arab, hemoglobin G, hemoglobin J, and there's a long list of structural variants. Daily structural variants, and this is another form of the normal. Quantitative disorders, the best example is thalassemia. Thalassemia is more prevalent than the other structural variants, لا همو عراق أو لا كردستان أو لا سليماني okay? لا سليماني لا صار يعني 4% of Sulaimani population are carrier of beta thalassemia mutation. While sickle cell is not a common structural variant. Page sickle cell hemoglobin D man here, delta beta man here, intra sickle cell mutation, not even disease. I mean the heterozygous. Sickle cell disease is not common. Now let's talk about the two forms of hemoglobin before entering into the sickle cell disease, just for your information, okay? Let's go back to the this slide. There's two forms that, if you like to have information, you can read more. Typically tense form, and the other thing is called the relaxed form, which is related to the movement of, or let's say the attachment between the four chains of the hemoglobin. If you say tense, it means the chains are very near to each other. Again, relaxed, it means they are at a distance of each other. And tense and relaxed, it's by the effect of binding of oxygen to the iron atom. I know this might be too much detail, but just have information. This is a pathophysiology, and it has a case you can read more. So what's the tense? It means the oxygen binds relatively poorly. Capillary relaxed binds easily. Why? I told you at the start that if oxygen atom binds, the affinity to binding more will be increased. So there will be, let's say, there will be easier binding of oxygen. That's all about the tense and relaxed two forms, but both of them related to the availability of oxygen. Transition between these states is influenced by a number of factors. Most significantly is the level of oxygen to which the molecule is exposed. Transition to the tense form is also facilitated by acidity in the tissue. So, sickle cell disease, like other qualitative hemoglobin disorders, I want you to understand the topic from this lecture because you will not have lectures talking about the bubbling pathophysiology of abnormality in hemoglobin. For example, a head-to-head lecture, and you will have thalassemia, and then you will enter into more clinical lectures. You may have, for example, clinical aspects or bubbling, the clinical parts of the thalassemia and sickle cell disease, but pathophysiology, hematology, bubbling, laboratory-wise, حلم lecturer baby زاني. وأجر if you like to do, for example, exams like جامعة البلاد USMLE, sickle cell disease is very common because it is common in black population. So the disease is caused by autosomal recessive. It is a point mutation which is inheritedly as autosomal recessive pattern. It's a single base change like adenine, okay? Adenine, يعني, subhanallah, adenine is changed by thymine and so on. But GAG is coded for glutamic acid, while GTG is coding valine at position 6 of the beta globin chain. So there is a mutation at the DNA level, changing the adenine by thymine. When this is translated into protein, or the bubbling globin chain, the amino acid produced from GAG is glutamic acid, while GTG is valine. And this happens at position 6 of the beta globin chain. This is the bubbling genetic mechanism or the underlying mutation that causes the production of hemoglobin S. And pale hemoglobin S because the shape of the RBC will be like a banana shape or sickle. The name is sickle, but they look like a sickle shape. Okay? So now we know what is the mutation. Now what's the effect of this mutation? This will change one of the amino acids in the polypeptide chain or in the globin chain, beta globin. Glutamic acid is changed by valine. Now what's the consequence of this change? It is not, this would affect the structure of hemoglobin. Some mutations will lead to change in the amino acid, but the change would not affect the function of the hemoglobin. This is good. But here, the function of the hemoglobin, the properties of the hemoglobin are changed. So this is the problem. Now these are normal happy RBC. These are RBCs. This is a hemoglobin inside the RBCs. So the picture shows you the change in normal conditions and if there is the sickle cell mutation. Now these are gel-like hemoglobin particles dissolved within the cytoplasm of the RBC. So if there is oxygenation or if there is deoxygenation, the hemoglobin is still like circular particles like what you see here. Now if there is this mutation which replaces the glutamic acid by valine. Now glutamic acid, this is just an extra information, what's the importance of the mutation? And it does not mere change amino acid by another amino acid. Now, glutamic acid is a polar. So this hemoglobin, when it is bubbling mixed with the plasma that contains a great amount of plasma is what? Water. So water is polar. Polar and polar, there is no problem. The hemoglobin wouldn't, the structure of hemoglobin is not changed. Now, when the glutamic acid is replaced by valine, valine is not polar. And there's a problem when it mixes with the water, which is polar. So hazaka to mix or to form a bubbling chain with the non-polar bubbling protein, like what? Like another valine from another beta S chain or phenylalanine it forms bonds. This hemoglobin will form polymers. This is the أساسي formation polymer. And this happens more when there is deoxygenation. Oxygenation, it would dissolve inside the hemoglobin. Structure hemoglobin. It wouldn't be available to form bonds with another beta-S chain. So again, glutamic acid is polar, and with mixture with water, there is no problem. I mean, with the plasma, oxygenation, deoxygenation, the hemoglobin is still like you see here. Now, when there is a mutation, whether one mutation or two mutations, one mutation is a heterozygous state, or a 20-plate carrier, a 20-plate trait, all is correct. Two mutations, it would be a homozygous, pale sickle cell anemia. But the topic, disease, what is disease? So consider that there's only one mutation. The beta chain is called beta-S, normally beta-A PLH, because it's adult hemoglobin. So beta-S, there's a mutation. Now valine on deoxygenation, which is non-polar, it will form a bond with another non-polar amino acid like phenylalanine or like another valine polymer to step. When there's oxygenation, the valine will go inside the chain, which is, this is the chain, okay? And it wouldn't be available to form, it will go inside the chain, and it wouldn't be available to form bonds. Why I'm mentioning this? The hallmark of the hemoglobin S is forming polymers. مشكلة كمان حلوة يعني polar and non-polar, this is not important. What is important is the polymer formation, like strand inside the RBC, okay? Upon deoxygenation. Now, if the RBC, this is an RBC, or this is an RBC, okay, this is an RBC, biconcave shape. If the hemoglobin is like this, it will be compressible and there is no problem. But if the hemoglobin is arranged in the form of strands, so this would affect the shape of the red cell. It wouldn't be biconcave shape, a sickle shape, strandi لناوي, polymeri لناوي, elongated مفهومة. Why the shape of the RBC? جماعتي دواوة. لجاتي بيركلي. So دواي الإكزاما أما قلت لك شرح هي أجر وابزا ميو ساعات بس reviewing case مية ذكرت شيء ما باسك دوا. يعني كل experience كم هو باسك. زور لوتان هي بس أجر طورو جانا يعني lecture بس أقال lecture previously زور سعيدي. زان لوتان زور. Okay. So I'm explaining why a biconcave RBC would change to this form. This is because of the strand or the polymer inside it, because of the change of the glutamic acid by valine, because of the mutation at position 6 or the beta hemoglobin chain. This happens on deoxygenation. Okay, a bit of oxygenation, it will go back to the normal morphology. But oxygenation, deoxygenation, a bit of permanent damage to the RBC, and it will stay in the sickle shape, which is this one. طبعا أما hemoglobin inside the RBC مفهومة جماعات. Now this represents the RBC, and this is the hemoglobin inside the RBC arranged in polymer. يعني the hallmark of the disease is polymer formation. So just understand this for me to explain the pathology before entering into the distribution. Second, this is a normal blood vessel and branching into two narrower branches. Now this is an RBC, which is normal, it's a biconcave disc, soft, compressible disc. And it passes through small blood vessels very easily because the inside hemoglobin is gel-like particles, so as any compressor there. But if you have a small blood vessel like these, and the RBC morphology is elongated, and the polymers will give the RBC rigidity, non-compressibility, rigidity, adhesion into the endothelium. So it will block the small blood vessels of ABD, and they have a tendency to aggregate. Polymer they will have intrinsic features that make them tend to aggregate and to adhere into the endothelium. So the end result is what? Blocking the blood vessel, blocking the supply, a bit of ischemia, and there is, after ischemia, there's what? Stroke. There is infarction. Okay, stroke, okay, it's correct. Infarction is terminal death of the tissue. It's not really healing. There is no healing. But ischemia, with the treatment, for example, vasodilatation, the tissue can get back to normal function. Now, if there is a blockage here, there is a dilatation or swelling which is very painful. So, two important things in sickle cell is the polymer formation. Okay, so we have polymer formation and the painful attacks can palliate sickle cell crisis. And thalassemia is a severe anemia or transfusion dependent functioning. But sickle cell is what? Sickle cell is painful hemolytic anemia. Okay? So keep in mind two things, the sickling attacks and the hemolytic anemia. So if we go back to the brain, the distribution, it's a disease of black population. Black population, it means it's common in, for example, Africa. See the maruna, the prevalence is more than 10%, زور 10%. Africa, but the southern part of Africa, say even in Mediterranean, in United States, Caribbean, بس همي African ancestry. لا UK يعني يوروب هرهوي بس همي African ancestry. بس مهما العراق ولا خليج الشام هي the Mediterranean areas هي northern Greece. لا Southeast Asia هي لا India هي. So it is widely distributed as you see here. We have to have information because you can see, for example, is the hospitals نخوش عربة بيني نخوش هلا هوليلا وهاتو لا دهوك وهاتو زور نازم هوليلا هيانا بس دهوك thalassemia center patients half of the patients are thalassemia major, the other half is sickle cell disease. So what is minimal sickle cell anemia? It means homozygosity for sickle cell mutation or mutation. So what is sickle cell disease? فرق sickle cell disease and sickle cell anemia شيء. Both are synonyms. What is sickle cell disease? What is sickle cell anemia? Sickle cell anemia basket though. What is sickle cell anemia? Sickle cell anemia homozygosity for sickle cell mutation. Okay, heterozygous YAG mutation here. Sickle cell anemia new mutation here. So what is sickle cell disease? The topic of the lecture in broad terms. Sickle cell disease
Inherited hemolytic anemia.
Inherited hemolytic anemia. Sickle cell like thalassemia, both are inherited hemolytic anemia. Examples of inherited hemolytic anemia. The sickle cell disease, it means under the umbrella of sickle cell disease, sickle cell anemia here, and the interaction of sickle cell with thalassemia, with hemoglobin O, with hemoglobin D, hemoglobin E. يعني it means it's يعني كأول sickle cell disease لو أنا sickle cell anemia ولو أنا interaction هي بين other thalassemia or other hemoglobin abnormalities. Okay? بس أوزان. كأحيانيته sickle cell anemia يعني homozygosity for beta S mutation or sickle cell mutation طبعا. بس كأول sickle cell disease doesn't mean always sickle cell anemia. It might be sickle thalassemia. يعني the mother is carrier of sickle cell mutation and the father is thalassemia minor, for example. Or the father is a carrier of hemoglobin C or hemoglobin O or hemoglobin D. So this is the difference between sickle cell disease and anemia. That's why designed. Again, we have sickle cell disease, which is symptomatic, and we have asymptomatic sickle cell trait. Okay, do you believe that sickle cell trait is totally asymptomatic? A normal person with this abnormal mutation, with bubbling this strong mutation, or what do you expect to happen in that carrier and when? Okay, I'm not get carrier يعني. So you expect that, okay, يعني bubbling water نقطة, but I didn't mention something because I will talk about it in the next slide. Now, we talked about the different types of hemoglobin. We said hemoglobin A is an adult, A2 is a minor, and we said fetal hemoglobin. Now, fetal hemoglobin is the predominant type of hemoglobin throughout the fetal life. and up to 6 months after delivery or postnatal life. يعني 11 شهر hemoglobin F is the predominant type of hemoglobin. The manifestation of sickle cell disease usually is not manifested throughout infancy or intrauterine life. Not infancy, sorry, intrauterine life. Sickle cell trait, can be symptomatic. So for the diagnosis of sickle cell disease or sickle cell anemia, as you like, the infant should be more than 6 months for accurate diagnosis. Boom, because there is hemoglobin F. So the mutation wouldn't affect the function of hemoglobin. Now, a mutation is happening in beta chain. Beta chain gene is present throughout from the early development of the embryo, which is correct. But the type of the hemoglobin that carries the function of the bubbling hemoglobin, oxygen transport, nutrients, whatever, is not alpha beta. It's alpha gamma, alpha 2 gamma 2, which is normal. So intrauterine life is normal because the hemoglobin is normal, which is hemoglobin F. After delivery, gradually hemoglobin F will be reduced up to 6 months. After 6 months, it would be hemoglobin A and A2 with very minor amount of concentration of hemoglobin F. That's why thalassemia level hemoglobinopathy, they will be bubbling apparent after 6 months. And you can't say that an infant or a neonate with 2 months is suspected to have thalassemia and sickle cell anemia. This would be very difficult and very rare. Hemoglobin F is the predominant type of hemoglobin throughout intrauterine life, and it's still constituted up to 70–80% after birth, and gradually declines to be replaced by hemoglobin A and a minor amount of hemoglobin A2. Up to 6 months. Some texts say up to 1 year. So after 6 months, whatever there's a problem with the hemoglobin, thalassemia, sickle cell, they start to manifest. Is that مفهوم point? Null sickle cell with 2 months, 3 months. This is difficult. Okay, what are the presentation? What's the presentation and what are the complications? Now, the hallmark of the sickle cell disease is these sickled, abnormal, rigid, fragile RBCs blocking blood vessels. So it's an inherited hemolytic anemia. Anemia, the lifespan of the red cell is shorter than normal. When you say hemolytic anemia, it means the lifespan of the red cell or red cells is shorter. But the lifespan later, the sickle cell is shorter. And I'm talking about abnormally structured hemoglobin because of a point mutation. Why the lifespan is shorter? Why there is shortened lifespan? Sickle cell disease or sickle cell anemia is a hemolytic anemia. I'm talking about a point mutation, and the RBCs would be abnormally shaped, rigid, they are not compressible as these MKB, soft, compressible, biconcave RBCs. There is an anemia and it is a hemolytic anemia. Why there is a hemolytic anemia?
Because of the lack of hemoglobin?
The hemoglobin, a qualitative disorder, the hemoglobin, what structural amount is normally produced. But the mutation may affect the function. But later, the morphology is changed, a rigid area. So then when it is rigid, it will be fragile. And with each attack of sickling, decycling, oxygenation, deoxygenation, there's a membrane damage. Permanent sickling, morphology, normal. So abnormal shape of RBC with deoxygenation attacks, there will be a detachment of the membrane of the red cell. If you imagine this morphology, parts of the membranes would be removed each time with the aggregation, with the contact with the macrophages of the spleen, for example. So the lifespan is reduced because the morphology is not normal, they are fragile. they would be destroyed each time they pass through small blood vessels, particularly the spleen. The macrophage will remove any abnormality from the membrane. That's why it's a hemolytic anemia. So the presentation would be after 6 months with anemia, jaundice, body jaundice. It's a hemolytic anemia. Bilirubin will be increased from the metabolism of the hemoglobin. Okay, what's important, which is very peculiar to sickle cell disease, is the occlusion of small blood vessels, leading to necrosis, infarction, organ necrosis, and severe pain. Now, you know why there is a necrosis or infarction, when there is a blockage of the blood vessels. Why? Because the RBCs are, the RBCs tend to aggregate with each other, and they tend to adhere to the endothelia of the blood vessel. Endothelia is the endothelial cells, which are the cells lining the blood vessels. So there's a blockage of the blood supply, and the blockage is painful. Like, for example, patient with MI, ischemic heart disease. It's painful because there's lack of blood supply. So this is the basic bubbling problem with sickle cell disease, but the manifestation is different. يعني قصدي كده. يعني the blockage of blood vessels can happen everywhere. You expect everywhere you can imagine. In the bone, in the brain, respiratory system, renal, eye, liver, spleen, even in the bone marrow. So that's why the manifestations expected to be of wide variety. So it's a hemolytic anemia, and we said that the manifestations appear after 6 months. It is anemia and jaundice because the lifespan of the red cells is shortened, because the morphology is shortened. Red cells are rigid. Sickle cell crisis is a new syndrome developed in a patient with sickle cell disease because of the mutation. So I told you, sickle cell crisis, it means the occlusion. Sickle cell crisis, the commonest type is the VASO-OCCLUSIVE crisis. Okay, there's different types of crisis. Probably the commonest, the easiest at this stage, probably VASO-OCCLUSIVE crisis, which is very painful crisis. It could happen in the bone, small bones of the hand and the foot. It could be, for example, in the long bone. Acute abdomen because there's mesenteric sickling or occlusion. It could be acute brain syndrome, which simulates the stroke, very fatal, and one of the grave complications. Acute chest syndrome. Again, occlusion of the respiratory organ, the pulmonary capillaries, preabrasive, everywhere. Some of the complications are not present here, but imagine that this occlusion can happen anywhere. And what there's a list of precipitating factors that enhances the sickling, or anything enhances deoxygenation. So this is the morphology of the sickle cells. Okay, sickle cell. You expect that any case suspected with sickle cell to see these abnormal sickle-shaped RBC in normal conditions, or the patient should be in a sickling attack. Yeah, easily. If a case, for example, suspected with sickle is referred to you with a history of attacks, do you expect the case to show these sickle cells if you do a blood slide or peripheral blood smear or morphology, whatever you like to call it? Do you imagine that we see these red cells always? So the answer is partly correct. Usually at the start, you see these in the sickling attack only. Yani when the patient is presented to the hospital or referred to your clinic with pain. So when you do blood film, you will see these abnormal looking red cells. But if the case is chronic, permanently, after cycles of sickling, decycling, and oxygenation, deoxygenation, the RBCs will be permanently damaged and will stay like this. But of course, in the sickling attack, the number of the abnormal RBCs will be more, not just few RBCs. Okay, you have to do complete the blood count and blood film for the case, and you have to confirm the presence of hemoglobin S by estimating the types of the hemoglobin in that case, whatever. Okay? So to confirm your diagnosis, the morphology is not enough. Okay, to sickle cell, the case would go into treatment of pain, blood transfusion, you refer the case to thalassemia center. So you have to be sure. How you confirm your diagnosis? You have to confirm the presence of hemoglobin S. Because this is a stigma. This is a sickle cell disease, and the family has, the case is sickle cell, and the father and mother are quite normal, you would be in big trouble. So you have to confirm it. You have to ask for estimation of hemoglobin S, either by electrophoresis or HPLC. The difference is just the mechanism of the test. Just you can write the estimation of hemoglobin S, confirming the presence of hemoglobin S. Also, you can do solubility test for hemoglobin S. Hemoglobin S is less soluble in comparison to hemoglobin. Okay, organs affected, I think it's expected to know all the organs are affected: bones, lungs, brain, kidneys, spleen, mesenteries, wherever you like to expect there is sickness. Now, what's important is the precipitating factors. Why is it important to know what's the precipitating factors?
Increase the chance of developing.
To avoid these sickling attacks, and it really works. It's infection, dehydration, cold weather, low pH, low oxygen tension. So these factors precipitate sickling. Infection, dehydration, cold weather, low pH, and low oxygen tension. Now I asked you at the start of the lecture, do you expect the carriers to be totally asymptomatic? Now, if the carrier is exposed to extreme, one of these, but in the extreme form, like severe low oxygen tension, high altitudes, for example, the plane flying very high, severe acidity, for example, and extremely low weather, they will manifest sickling. تجيب لبنوا كود كاني كنكاتي عسكرية at the army service. Sickle cell, this is in areas where prevalent with sickle cell anemia, they were not accepted as soldiers. Okay? So because of these complications, they said that the renal complication is higher in patients with sickle cell trait in comparison to normal population. And there's a sickling in the renal circulation. Of course, after exposure to extreme conditions. Now, we said that VASO-OCCLUSIVE crisis is very painful occlusion of variable blood vessels. يعني Spani lecture whatever. Already.
Is there?
Why pinch the Jared? There's still a time. So, can anybody tell me how we can manage sickle cell disease or sickle cell anemia, or a patient presented with painful crisis, like for example hand-foot syndrome, occlusion of the small blood vessels of the hand or the foot? Jamaat, power here. Oh, we don't know. Like you? يعني نسيت لو تان نسيوها كيف تان أو تان؟ يعني the lectures for your own sake. أجل وين بودا خلاص. يعني سكشني كي حاجة كجيوبك استفادة بس نبت بدأ ما يكونات عندنا بقعة تواني. خوشي ختاي يومي السياسة تلا بزور ولا ما كان السياسة بنازم تصورنا. بس it's for your benefit. يعني إما يشيخون بجهري ديوتي ماني بس ما يتوه استفادة فيه. دوائك failure rate does a better online PCR كان قرصة. But some of the points mentioned here, you will miss it شو كتركيز النظام. So can anybody tell me how can I manage a case of, for example, painful crisis in hand and foot, for example?
Give painkiller to relieve pain and oxygen therapy because
painkiller severe up to the level of morphine and hours, quite severe pain. Okay. Then also oxygen to induce oxygenation, يعني de-sickling, sometimes vasodilators.
antibiotic.
If there's an infection, antibiotic. Now, do you think that prevention is important? Do you know what's prevention? I mean, at the level, at the stage of marriage, two carriers. This is called prevention, يعني screening. If the couple is both is a carrier, then you have to go to the stage of counseling. You explain the, let's say, what's the expected rate of incidence of sickle cell anemia in the two carriers. So a mother and a father who are both sickle cell carrier, what's the percentage of sickle cell anemia in the offspring, according to Mendelian law, genetic? Okay, how many are carriers? Yeah, if the 4, 8, it means 50%. And 1 would be normal, no? But the reality is not like that. Now, I have tried sickle cell anemia. So, it's just, it's not, and that's why in countries where there's a prevalence of thalassemia and sickle cell anemia, there should be prevention. Genetic counseling, testing of the fetus, and allowing abortion if it is indicated. This is the only way. Is there gene therapy? There's a gene therapy, and also there is marrow transplant. So as you said, there's avoiding the precipitating factors, oxygen therapy, painkillers, use of drugs that stimulate hemoglobin F production to reduce the sickling, vaccination, and oral penicillin use, because one of the organs that will be impacted early in life, early in childhood, is spleen. And what's the function of spleen, by the way? What's the function?
Blood production.
So interesting. One of the functions of the spleen. Yeah, this is one of, but this is physiology, exactly, yes. Then, what's the function of spleen? The red cells will be break down within the macrophages of the spleen, yes. The aged RBCs, or abnormally looking RBCs, whether they are aged or like sickle cell disease, or the membrane is abnormal for whatever reason. What else? What? Okay. So filtration is a part of the immune function offered by the spleen, because there's a white bulb and there's there's lymphoid follicles inside the spleen. So the spleen is a site of immunity, particularly early childhood. So that's why there's vaccination and oral penicillin use, because the spleen is infected, so there's a loss of the function. That's why the case would be liable for infection. So that's why I'm explaining the points to be easy for you to memorize: vaccination and oral penicillin, because there's a high rate of autosplenectomy. And the spleen is in its site, but it's not functioning, because there's occlusion of the blood vessels. That's why you need to put the case on a schedule of vaccination and penicillin, oral penicillin. Also, genetic counseling, which is the most important point. The couple is a carrier of both partners are carriers of sickle cell disease, then you have to counsel. You mentioned the reality, because the carrier is almost asymptomatic unless there's extreme conditions. And they have the right to choose. Okay? What's important also is the drugs that stimulate hemoglobin F formation. Let me explain this quickly. Hemoglobin F, it wouldn't allow the polymer formation, yet in our rusty beta chains, it will inhibit, or let's say more realistically, reduce the polymer formation. That's why they use it, hydroxyurea, okay, which is regarded as a chemotherapy, but it reported a good success rate in treating sickle cell anemia by reducing the rate of polymer formation, bacteria and so on. But what's important more than all these is that genetic counseling and the prevention. Always have to prevent better than treat. Even the resources you buy bubbling oxygen, painkillers, you need hospital, you need beds, vaccination, antibiotic. So this is a disease which is very painful and quite common in your country, in parts of Kurdistan and in Iraq, in the neighboring country, and you have to have good information. And in this topic, we only touched upon the things that we mentioned. Otherwise, this is a very long story and lecture. طبعا أكيد بس يا ثانية.